Okay, good morning, everyone. I've got top of the hour, so let's go ahead and get underway. On behalf of those of us here at Medical Advantage Group, as well as the Florida Association of Health Plans, we want to welcome you all to today's session, Accelerating Success in Value-Based Care. Before we jump in, a couple of housekeeping items. First is all the phone lines are in listen-only mode. During our presentation today. We will be pausing towards the end for questions. So if you have a question you'd like to submit, please go ahead and use the little question area of the control panel, your GoToWebinar control panel, and we'll take those at the end. And as always with these things, once we're done with our session, all registrants will receive a copy of our materials as well as a link to today's, the recording of today's session. Okay, I want to do a quick just summary of Medical Advantage Group. I know for many of you on the line, this is our first introduction. We are a subsidiary of the Doctors Company. This is an enterprise company, medical malpractice firm with a nationwide footprint. Our parent insures over 80,000 physicians and holds roughly $4 billion in assets. So we're in all 50 states and part of a very financially strong organization. The key words here are, on this slide is the in-practice support. That's really the heart of what we do. Our work in the world of value-based care is really in the ambulatory space. We help practices improve their core operations so they can be successful in their reimbursement programs and ultimately provide better care for their patients. Our model is very hands-on. As Paul liked to say, we put people in cars. We're the true partner of a practice working on behalf of health plans. So if you look at our positioning, we're really in between the health plan and the provider. Many times working on behalf of the health plan. As a physician-owned company, we come on our work with a deep understanding of how the delivery system works, how to motivate and change that side of the world. We're working very hard to make relationships between health plans and delivery systems more successful. I'd like to take a minute and introduce our two speakers for today. Mr. Paul McClellan is the CEO of Medical Advantage Group for the past 4 years now. He's led the company through a lot of growth in terms of new markets, new services, greatly expanded geography. Prior to Medical Advantage Group, Paul has over 10 years in a large regional health plan and knows the health plan side of things very well, the shoes that you all have to fill to be successful. Darlene Elreda is a public health epidemiologist with more than 15 years industry experience in a variety of settings, academia, health insurance industry. As our Director of Population Health Strategy and Analytics, Darlene leads a team of data scientists in the analysis of clinical and payer data. So it's her team that's producing the actionable insights that are typically leveraged by our in-practice staff. Before joining Medical Advantage Group, Dr. Elreda held a variety of roles in public health, including at the Centers for Disease Control, Michigan Department of Community Health, Michigan State University, and Blue Cross Blue Shield of Michigan. So welcome to both you guys. Let's quickly just hit our topics for today. We're going to start just talking about the current landscape of value-based care, where are we at in general. We'll touch upon the critical relationships between payers and providers in this space. We'll hit on some of the current issues and challenges around value-based care that we're seeing in our work today. Talk a little bit about the financial opportunities. The stakes in this area are really increasing as we go forward. We'll give our thoughts on the road to success. What are some things that will be successful in the future? And then we'll end with a couple of case study examples. But before we jump in, we want to learn a little bit about who you all are. So let's just do a quick poll here. If you could please just describe your role. whether you're with a health plan. I know we've got a number of people from health plans. If you could just indicate, are you responsible for quality or maybe the provider network integration? For those of you on the provider side of things, maybe you're a part of the office staff, an office manager, or a clinician yourself. I think we had a couple of actual physicians sign up, so just please let us know. I'll let this go for just another second. Looks like we've got most of you voting at this point, so let me close this. And now we can take a look at the results quickly. It looks like 40% are with health plans responsible for quality. And then, let's see, 20% health plan provider network, 20% office staff, and everyone else is basically other. Okay. Thank you for that. So now with that, we can get into the material. So Paul and Darlene, let's start just by talking about the current landscape, and we can roll from there.
Sure, terrific. Well, I guess just to start with the poll results, it's great that we have a good mix of people, and it's a lot like the mix of folks we have inside our team, where we have a variety of folks who come from all backgrounds and help glue the world together for value-based care. You know, I see on the screen the current landscape. We seem to have a growing number of words and terms on how we describe what we're doing, right? Whether those are ACOs or risk-based contracts or surplus sharing agreements or gain sharing agreements or incentives or carrots or sticks, many different ways to describe what's going on, right? I look back at the last 5 years, and it's remarkable how quickly we've evolved to where 5 years ago we all seem to be just beginning to dip our toes in the water and experiment. The formal, CMS ACOs were in their early days, and now we're really have quickly evolved to a place where I don't think there's a health plan I come across and talk to that isn't actively involved in value-based care, and likewise, there's very rarely a delivery system group, whether that's a large integrated system or whether that's an IPA, that isn't holding some sort of value-based arrangement. So we've quickly gone from putting our toe in the water to this is really mainstream and a core part of how the healthcare financial reimbursement model works today. So with many different names, I think it all comes down to a couple things we're trying to manage, with a couple things that we use to guardrail and keep the system fair, right? In the end, this is all focused on cost and spending the limited resources we have the right way, right? And the way we do that is through quality. So we're collectively putting our bet on public health theory. We're collectively putting our bet on PCMH, right? That if we do the right things early on with our patients, and if we carefully track and take care of those who have chronic disease, then collectively we'll do better at, most importantly, taking care of those people, but then secondarily taking care of our collective budget and how much we spend as a country on healthcare, right? And so quality is really our gate to managing cost, right? And then of course we sprinkle in risk adjustment so that it's a level playing field, so that the budget that everybody works in all of these arrangements is fair, given the mix of patients they're caring for. I think that, at least in my view, the next big thing that we'll see come online in the next few years is really figuring out how are we going to factor in social determinants into risk adjustment, right? That I think we're all would agree that not all zip codes are equal, and where you live and your income and your social stature in society has a lot to do with your overall health. That's something that I don't think we have very well integrated yet into these models. A lot of people are talking about it, sort of like we were all talking about value-based care and ACOs 5-7 years ago. So it'll be exciting to see that come online, and I think help people have a lot a fairer playing field. But in the meantime, we have developed a system primarily driven with quality benchmarks and spend benchmarks, where the likes of us on this webinar have sometimes tens, but most likely hundreds of millions of dollars now in play in doing well in these programs. So they have grown to a state in health plans, whether it's a commercial ACO, whether it's a state-run Medicaid program, right, that is quickly coming to Florida, where we're specifically speaking to today, or whether it's Medicare Advantage or it's a traditional CMS ACO. The stakes are ever increasing on how these programs work.
Thank you, Paul. So let's talk about the relationships.
Sure. So I'm going to go back in time for a second to when I used to work at a health plan, and I know we used to sit around meeting room tables and scratch our head on why is this so hard. It seems like the things we need done inside physician offices are relatively straightforward, right? It's the basic blocking and tackling of quality metrics, doing preventive care, taking care of folks with chronic disease, getting the right tests done, making sure prescriptions are refilled, making sure follow-ups happen after admissions, the basics, right? And we still really struggle a lot on the basics, right? We have some metrics, I'll say easier metrics, where we're all clustered around the 90-something percentile and we're doing great, right? But most of those are relatively easy things. The tougher metrics, like controlling blood sugar in diabetics or controlling high blood pressure, right? We still have a long way to go on getting those metrics on where they should be to have full and proper care. And it's, why is this so hard, and how is this so disconnected? And part of the challenge, I think, is we initially set up a system with the incentives not aligned. So health plans are judged by the likes of NCQA and CMS and their state Medicaid department, all around how well they do, in HEDIS, right? First and foremost, so the health plan is responsible for running a high quality network that gives good care, right? And then at that point, the network is the network, right? And health plan, speaking as a former health plan person, we try not to get too directly involved in the day-to-day care of our patients inside doctors' offices, right? That we don't really want a repeat of the 90s where HMOs went sideways on being too prescriptive on what can and can't and should be done. Right? So we've really empowered physicians to do that. But then we've set up an enormously complicated system of administration and documentation and measures and hoops that the health plan themselves don't have direct control over in the doctor's office. So we have this arm's length relationship inside the office, and then we have some metrics that are certainly important and good gates of how the overall system is doing. But in the reality of a doctor's office, when you're dealing with really sick patients and you're dealing with people living and dying and you're dealing with telling family members that their loved one has cancer, all of these, wow, I didn't quite record the BMI right in my EMR, is a big who cares moment right inside the practice, especially if you walk into that practice when they're having a difficult day and there's some patients really struggling. So working through how do we get these relationships to where they're partners and we're all seeing the world the same way, and fully understanding that these measures do matter because they are the measures by which we're collectively measured and we're collectively paid all the way up the value stream, is tremendously important.
Thank you, Paul. So let's get in. That was great from a high level. Maybe we can dig in maybe to the next level of detail around some of these challenges.
Sure. The reality is we use a term called value-based programs, and they are not all created equally, right? Right now we see a wide variety of programs that have different measures and different methodologies and different ways to assess performance, and even more complicated methods to assessing relative performance of physicians and physician group practices compared to one another. The net of that is the programs are really complicated, and a great majority of physician practices simply don't understand the details of how these programs work. And what we often hear is that there's been quite a bit of investment in tools to help bridge that gap in understanding, or help people focus on what they need to focus on to make them successful in the programs. And what we hear a lot in working with physicians is many of these tools unfortunately go unused or underutilized by practices. Examples of tools are things like data portals that health plans may invest in to quote unquote push out data that they believe physicians need to have access to, or what people call reporting platforms. Where can I go to see how I'm doing in this program? Or the electronic medical record inside a physician practice, right? Probably the most prevalent tool, technology inside practices today. And the great majority of physicians we speak to say the basics. I can do the basics inside the electronic medical record, but may not be taking advantage of all the bells and whistles that technology has to offer. And in the words of my high school math teacher, the technology is necessary but not sufficient to solving these complicated problems that we're facing today. And what do we hear about one layer lower in terms of the challenges? So no one can argue that in this day and age of big data, that we have an unprecedented volume of data, right, coming at us at a speed or velocity that we've never seen before in the human race. So we have a lot of data and a lot of information. The challenge is we are data rich and likely insight poor. What does the data mean? We also have inside practices limited resources, right? The number one focus inside the practice is to deliver high quality, the best quality care we can to patients. And we often hear it's a challenge for practices to then dedicate time to implement new processes or whatever changes they need to make to also then be successful in value-based programs. We often hear that there's insufficient training for success in these programs. We hear health plans don't provide the necessary level of training and guidance for practices to understand the requirements and how to integrate tools and technology into their current workflows, such that they're not seen as interrupters on how they run their office and their practice. And we often hear, and it depends on who we're talking to, we often hear issues with motivation. Are the right people motivated to act on the right things at the right time? It goes without saying that the great majority of providers, if not all providers, are already doing the right thing for their patients and lose motivation in these programs, because while they believe they're doing the right things, they're frustrated that they're not seeing the result, their performance reflected in these assessments and in these reports and in the incentives, right? Most practices lack a catalyst to drive them into action. They need an individual who can learn the ins and outs of these value-based requirements and programs and determine how they can fit within the practice that they're running, and help guide the practice through implementing or tweaking their processes or their knowledge base to be successful in not only delivering efficient and high quality care, but also doing it such that it's reflected in the assessment of these value-based programs and that they're rewarded. So you break that cycle of lack of motivation.
Okay, very good. We're going to stop again for another poll question. Now, the goal here is to not turn this into a big complaining session, right? We're just curious for your thoughts, given some of the challenges that Darlene and Paul have mentioned. What are your thoughts on some of the challenges you all have faced? We will take these results and try to talk to them as we continue on with the rest of our session here. So let me just launch this next one. Please just share your challenges with value-based care. Same deal, multiple choice. Okay, got about a third of you voting so far. Give it just another couple seconds and then share the results. Wow, everyone voting. Very good. So I'll stop here.
We have a nice mix of folks on the line, so I'm going to guess we have a nice mix of evenly distributed answers.
Yes. Let's see. It looks like the winner, 40%, Darlene, is data integrity, data connectivity issues.
All right. Darlene paid off.
No, I didn't.
25% are challenges around programs changing year over year.
That's true.
Mm-hmm.
Different metrics used by different payers, 20%. And unclear methods of assessing performance, 15. So it's a pretty even distribution. All right. Thank you very much. So with that, let's go on. These are some things we published a white paper recently, and these are some of the things that we talked about in the paper. So I think some of that was just validated by the poll results. But Paul, Darlene, I don't know if you guys want to touch on any of these before we move on.
Yeah, so I think I heard you say 20% of our audience talked about lack of transparency regarding the method or the metrics and the data used. This is a big one. We hear this everywhere, across payers, across the system. This is key, and this is only going to get better when the payers and the physicians and the practices and all the stakeholders in this challenge of value-based care are able to get into a room together and talk things through. The reality is, because of the 40% of our audience that actually talked about data integrity and connectivity, because there's so much data and it's sitting across multiple sources that, and it's hard to bring it together and still have it tick and tie and make sense. Many of the payers, and not to their fault, who really have actually been bold in pushing on value-based care, being first. There's a cost of being first or being bold and big, is that many of them also hadn't figured out how to the most efficiently click the data together and still have it have the integrity and the checks and balances. And many of them have relied on vendors to help them do this. The challenge with many of the vendors in this space are that indeed they are vending methodologies, they are vending algorithms. And so part of that relationship is such that they cannot then make transparent the methodology, right, even to their biggest customers. This is a very big challenge that the industry needs to continue to work through, because you hear it, in grade school. I need to know how the teacher is going to calculate my grade. Then I'm motivated to address my problem areas and my challenges. So this is a very common one. This can be overcome. This takes partners at the table talking about it. I think that I think 1 and 2 are connected. That when the stakeholders are at the table together, discussing challenges with methodology and transparency and black box methods, that's your first step to ability to influence the methodology and the metrics, right? And I think that payers need to be really sensitive to the fact that the great majority of physicians and providers absolutely want to do well. These are highly motivated, driven people, but they want to understand how the method works and how they can do well. Lack of alignment, between practices and other healthcare providers. We hear this a lot. I think this is part of that building the bridge and trying to cross it at the same time that we're trying to do here in the US. This speaks to, it's really a challenge for physician practices to be held to, cost and utilization performance metrics, for example, and maybe not have a choice in the hospitals that their patients see, but then the same health plan that's assessing them on cost and use may not have alignment with their hospital reimbursement structure in the same locality, right? Such that the hospital stakeholders may not have a vested or financial interest in working with the providers that are sending patients their way. You want to take the...
So I was just going to add a couple things, right? I guess I can take the everybody has different sets of metrics and methodologies, right? I think we're inching our way maybe in the next 5 years to where we'll have a more common set of metrics and methodologies, and I'll give a preview of that, I think, in a slide coming up. But I think overall the net, it's my experience in this world is it's very tempting for folks engaging on this journey to quickly disengage over data, right? That the data is not good, the data is not good enough, the data is not clean, right? I think healthcare transformation and value-based care is a little bit like the survival shows my kids watch on TV, where we're going to be taking some chances and drinking from dirty water sources for a while as we work through this, that the data is not perfect, right? The EHRs were not made to be value-based care platforms. Health plan membership and claims processing systems were not made to be value-based care platforms. And what we're doing right now as an industry is stacking a lot of technology on top of those core things that were never really developed to solve the problems we're trying to solve now. So it's going to remain difficult, right? There's just too much money at stake and too much innovation in play for us not to break through that in the coming years. I don't know who the winner will be, but we will find leaders who really have population-based solutions that work from the ground up on the clinical side of the world and on the payer side of the world, right? And I'm rooting for everybody to get there because we all need them to get there. But in the meantime, we have to design our programs, we have to design our engagement strategy with the physician community around starting with high-level metrics that show trends. If the trend shows that you follow up with your asthmatics to make sure they have a refilled prescription half as much as everybody else in your community, you can argue whether the numbers, your numerator is 1 patient off or 2 patients off, but the data wasn't designed to be equally unfair for your particular practice or your particular location, right? The data shows there's something dramatically different between you and everybody else, and it's zeroing in on those big variations that I think are where we all need to start, and that's where there's tremendous opportunity, right? When we clear all that easy stuff out of the way, we'll have great demands for more refined data, but we've got a long way to go. I think we collectively have years of work to go to get through the big block, screaming off the page trend things before we get to the next level of things where it's really going to matter on high level interventions that are going to help make practices deliver care differently and then capture everything during that different care so that everybody gets credit.
And I think maybe on number 5, that each payer has a different set of performance metrics and methodologies. That's going to take a really long time to solve, if it's ever going to be solved completely. However, as a public health person, I see this a little differently in that I back up a little bit and talk about it is far easier to take a list of a set of patients that needs 100 things and work down the list with the highlighter and cross things off and get it done. That's the tactical way to quote unquote improve your performance in a set of measures or metrics. But you could also take those same lists, look at it for your entire population across all the payers that you're seeing in a practice, and ask yourself, are there processes here that are suboptimal that I don't have at the practice that may be contributing to the generation of this list to begin with? For example, you can look at how you're doing on preventive screening for subpopulations, adolescents, children and the such, and ask yourself, do I have an outreach process? Do I have a process that looks at my data across all payers and actually tells me, every Monday morning, here's the set of patients that I haven't seen in 3 months, 6 months, 9 months, right? So I'm more of a backup into some processes that may not be working exactly as designed or intended, make some tweaks to processes, and some of the pain and challenges in the metric performance by process level tweaks.
Some logical places to start as you live in the sea of metrics, right? If you serve a senior community, start with the Medicare Advantage metrics. They're national and they're the same, and ultimately all the payers upstream are measured the same way. So as a practice that serves seniors, that's a great place to start to understand the metrics, understand how risk adjustment works, understand what needs to be done in a wellness visit, understand what your biller needs to do to make sure you're getting credit for what you do, right? That's an obvious place to start, right? If you're a big peds practice or a family practice, you probably want to start with your partners in Medicaid, because they are likely the majority of your patients, and over time they're assembling into more common measures as well. So on the slide, I know we're on a webinar, sponsored in partnership with the Florida Association of Health Plans. So I did not fall on my head on the way in. I know that that's Ohio, not Florida, highlighted, but I think Ohio is a great example to speak to on how the market's evolving and what's happening. And in the land of Medicaid MCOs, Ohio is a few years ahead of where Florida is right now, where Florida is just getting into value-based arrangements in its beginning. Ohio's now several years in, and there's several reasons why I think Ohio is a good example to talk about with Florida, right? One, because Ohio moved to a full MCO model, very, very interesting. But if you look in Florida and you look in Ohio, what you find is, boy, there's a lot of the same players, right? There's still lots of regional health plans, and those are alive and well, but there's a tremendous amount of consolidation going on in the industry. So the likes of WellCare and Centene and Molina and United Healthcare are ever increasing their footprints around the country. And as they do, right, they have no desire for a program to be different in every darn state, right? That's just more IT work for them to keep sense of all of that in their system. So there's a push to consolidate geographically from that side of the world. And then if you look at how states design their programs, they typically bring in a third-party partner like a McKinsey or like a Deloitte or like a PwC, and those folks have a standard toolkit that they take from state to state. So if we were to look at the Ohio plan and we were to look at the North Carolina plan, wow, they look remarkably similar. And look at that, they hired the same consulting firm to design their programs, right? So there's forces bringing things together, and then of course there's the ever-growing big guys in the delivery system, the Tenets and the Trinities and the Ascensions. As they expand their footprints, they're driving for consistency as well. So I think consistency will come across Medicaid plans even as we let states have more power on what their Medicaid plan has. But all of that said, Ohio is I think a typical model that we'll see moving forward, where they started with a potential bonus you could earn based on how well you did in your HEDIS metrics. That bonus largely went unearned and has evolved from a bonus to a withhold, and then has increased in size as a withhold, right? And the benchmarks are relatively fair. The state chose benchmarks that were the national Medicaid benchmarks in quality, and you start getting paid in that program as a health plan, and then downstream as a provider, right, depending on the Medicaid plan's design, for getting out of the 25th percentile in your measures, right? It is not you have to get to be the very best in the country. You've just got to get out of the bottom 25%, and you start earning your withhold back. And those withholds, even with them doubling, are still going largely unearned. So the state is demanding attention on those measures, and there's literally hundreds of millions of dollars at stake.
Okay, very good. So at this point, we've talked about some of the background of the program. We've talked about some of the challenges, and Paul just covered the financial opportunity. So why don't we shift and start talking about how to get there? What's the road to success?
Sure. So I'll cover this one, and I know we have 20 minutes left, so I'll work to go quickly. On the road to success, I'll touch on a few things here. How to engage practices is really key, right? Your strategy for engaging a large integrated delivery system or a large physician group that operates under a single TIN versus loosely affiliated physicians in an IPA is different, and you need to have a strategy that compels to has a compelling argument to the people that you're talking to. What is in it for the practice? Are we going to help with physician burnout? Are we going to help with practice throughput? Are we going to help with top line revenue? Are we going to help with the metrics by which you're held accountable to in your larger system? You have to think through models that will actually have a reason that an individual practice, right? And by practice, I mean some medical setting with chairs in a waiting room, has a reason to listen to you, right? Because there's 100 people that want to be listened to in any given week that want to drive behavior in that practice, and you've got to have a compelling reason. And then as you go through these other bullets, it really works around have a compelling reason. Start with building trust and understanding how the practice works and why it works that way, right? People did not design their practices to work in a way to be difficult. Right? There's a reason they work the way they do, and you need to show up with respect, understand, and then work through changes in a prioritized way where we're going to work on one or two things at a time, and then we're going to work on easy things first and put some wins on the board that are wins to the practice, right? Not wins to the health plan, even though it's the health plan likely funding this work. It has to be wins for the people that are doing the work, or these programs never get off the ground. We have a bullet here that says leverage technology. We're not big believers in more technology because we're at a technology surplus right now. We've created way too much technology, and we need to pause and have some of this technology actually work together, and then give our partners in the delivery system a roadmap on when to use what for who. Right? It is enormously confusing when a practice uses 15 or 20 different insurance products, and everybody has a different set of tools and expectations. That needs to be simplified. So this next slide, I'll just spend 30 seconds on. This is what we do when we do this. We start with engagement, right? And I talked about that, having a compelling reason to get past the sliding window and actually have somebody be willing to work with you and give an hour of their week or an hour of their month into listening and learning how to change. Right? When we get that opportunity to be a partner in change, we start with observing, understanding the sophistication of the staff, understanding their knowledge of how insurance programs work and value-based care works, understanding what technology they use, understanding the workflow and how are MAs used, how are PAs used, what's the doctor's role, what's the office manager's role, right? And all of that matters as you take what do we need to achieve from a metrics perspective with what are the capabilities and behaviors in the practice, and meshing those together into a really carefully orchestrated action plan, one location at a time, that will deliver results, right? And then we repeat that circle.
Okay, so at this point, why don't we talk about a couple customer examples?
So in the prior two slides, what Paul described was, our solution that we call Practice Catalyst, and the key word there is catalyst. What do we do, and how do we catalyze action inside of a practice to achieve results? And these are snapshots on a large physician organization that we support, and some results in moving their NCQA quality metrics. Over to the left, you have number of metrics in the 90th percentile or greater than 90th percentile, increasing over time. We have overall quality of care on an aggregate scale across their metrics, showing a 25% increase in overall aggregate reporting for this client. And then on the next slide, we have, for example, we chose a really complicated metric, which is hemoglobin A1C control for a client, and we've been able to see a decrease of out of control hemoglobin A1C of 46% for that population, down to 24% over a couple of years. I think the key to this chart is that, and then melding it together with our approach is, yes, it takes time to build these relationships. Yes, it takes time to understand how each individual practice works. But it's an approach of relentless incrementalism. It pays to dedicate the time and resources to build those relationships. For the most part, those are the providers that the payers need to work with for the foreseeable future in that given geography. But the metrics will improve with that dedication of time and resources and approach.
Okay, excellent. We've got about 15 minutes left, which I think is perfect. This gives us some time to take some questions. We've had a number of questions come in, so thank you all for submitting them. Let me see if I can kind of paraphrase. We've got a couple of questions around the same general topic, which is basically around how to start. Where do I start? There's some that seem to have more of a data platform, or which is the best one, or they've invested in analytics but don't see the return. How do I get started? If you guys could take that one.
I'll start, and I think I'll just pick up right with one of the last phrases Darlene left off with, which is relentless incrementalism, right? It all comes down to starting with a reasonable sized problem, with a reasonable sized geography, and an approach where you're not looking to boil the ocean, right? That I've lived on the health plan side of the world and the delivery system side of the world now, and I can say from both sides of the world, arriving at a practice or a health system with a set of reports that enumerates the 85 different measures on which you're underperforming is not helpful, right? That's overwhelming at all levels, right? It instills just a mood of helplessness and defensiveness right away, right? We're great. Haven't you seen our commercials, right? We have the most dedicated doctors who are so passionate about what they're doing. This can't be right? Like, starting with an all red report or an all red dashboard isn't helpful. Starting with let's work on everything isn't helpful. I think really starting at some simple things where you can win together, where there's metrics, whether they're cost or their quality or the risk adjustment, but where there's an obvious problem with an easy fix, where the health plan really wants that problem fixed, and there's either an administrative burden relief or financial reward on the delivery system side, is key to finding someplace. You got to find someplace to break bread, right? And get a little win, and then keep building on those little wins until you've got a holistic program in place.
Excellent. This next question, Paul, I think just builds upon that one. It's about just the people we send, our in-practice coaches, and can you talk a little bit about their background or the profile?
Sure. I think the key here is that they have a wide variety of expertise and education and training. Many of the people that we send to work inside practices have come out of practices, right? They're prior practice managers. They may be prior nurses, people who have worked both for inside physician practices, delivering care management, or actually as a part of the care delivery team, or they're nurses that have worked on the NCQA side and they've done chart audits and chart pulls, or they've worked on, payer health plan delivered care management. Some people have a background in technology, right? So they understand how to go in and diagnose. You've invested in this expensive, technology. Why isn't it work? You're saying it's not working for you. Show me what you're trying to do. We've got a wide mix of, we've got some public health people, some practice people, some technology people. The fact of the matter is, trying to improve the quality and efficiency of care delivered in the U.S. really is going to take a hybrid set of skills and expertise. This is not a technology problem to solve, and it's not a clinical problem to solve. It's a combination of challenges, right?
And what I'd add to that is as you build your teams to solve these problems, think through your model, how you're going to de-silo those teams. I know that's not a word, but I couldn't come up with a better word. But I'll give an example. The gentleman that runs our EHR optimization practice and is out helping physicians get their EHR, I won't say to be their friend, but their non-enemy, right? My EHR helps me be productive in my visit versus the EHR is the bane of my existence, right? Which is where a lot of practices are with their EHR. It just so happens the person who runs that practice works out of a building that also has 25 care managers in it. So he can walk down the hall and talk to a social worker and talk to a pharmacist and talk to a nurse and say, how does this really work? When you're charting, what do you really want to know? How do you really want to see this? And having that interaction of people who come from different backgrounds, and your analyst coexisting with your technologist, and your technologist coexisting with some clinical people, finding ways for those folks to collaborate, right? Or whether it's physical is magic, right? Because it's not the individual skills that are the true magic. It's those people all knowing each other and being able to call on each other and help each other. That is the true magic that we found in our approach.
Okay. Before I take us out, any final comments that you guys want to share?
I think for me, what I'm reminded of on a regular basis is that right now, when we talk about the challenge that's ahead of us, we talk about sides, payer, provider, patients. And I think that the work starts when we agree to start, that we're actually all on the same team and all on the same side, trying to solve the same problem. We're not there yet, but even having the conversations and having all of these players in the same room at the same time is really a fabulous place to start at a time in history where we have more technology than we've ever had before. So we actually have the tools that the three parties need to actually become a winning team in this challenge.
Okay, very good. So with that concludes our session for today. Before we go, I want to acknowledge the Florida Association of Health Plans and specifically Audrey Brown, the president and CEO, for helping us promote the session today. Audrey actually helped us prepare some of our materials that we presented today. So thank you very much to the FAHP. We'll be in touch with all of you shortly with the follow-up material. As I mentioned, a lot of what we covered today was recently published in a white paper. So in addition to the recording, we'll send you a link to the paper itself. On behalf of Paul, Darlene, and myself, thank you all for joining us, and we hope to see you again soon on the next Medical Advantage Group session. Please enjoy the rest of your day. Thank you.